Today on AIDS Vision, we're going to be talking about the alternative test sites and their new education program. A whole new state-funded program of billboards, public service announcements, and posters. Are they getting the message across? Find out on AIDS Vision. Welcome to AIDS Vision, and I'm your host, Allison Arngrim. And today we're going to be talking about the Alternative Test Sites Education Program. With us is Dean Licitra, who is the Alternative Test Site Program Manager from AIDS Project Los Angeles, Jordana Raskin, who is the Alternative Test Site Project Director at the Edelman Center, and Mary Huttner, who is the Chief of HIV Testing Unit from the State Office of AIDS in Sacramento. Welcome to AIDS Vision.
Thanks, Allison.
I think the first thing we should probably talk about is what exactly is an alternative test site. Jordana, you are at Edelman, where they actually do the testing for HIV. Can you explain to us what exactly it is you do?
Yeah, thank you. We run an alternative test site which is anonymous as opposed to confidential, and we offer pre- and post-test counseling for people that are interested in taking the HIV antibody test.
Now, what is the difference? We hear this a lot, anonymous testing, confidential testing, and we tend to think of that if someone's keeping something confidential, it's anonymous. What is the difference technically between having an anonymous test site as opposed to confidential?
That's a really good question because there is a lot of confusion about that. At an anonymous test site, there is no association between someone's name and their test. We don't know their name. We go by a number code. And so oftentimes when people are concerned about where this information might go in terms of employers, in terms of doctors, in terms of insurance, going to an anonymous test site, they know that they're going to be the only person getting that information.
So your friends, your neighbors, your doctor aren't going to find out. Now, whereas confidential, it isn't really told to people, but it's still, there's some record kept. Is that the difference?
Well, your name is being attached to it, so there's always a question involved. Sometimes people prefer confidential if they need written documentation for different purposes. But otherwise, an alternative test site where there's anonymous testing makes it a little bit more reassuring for people that they are the only person that's getting that information, that no records are kept on that.
Now, if you go to your doctor, the price of a test can vary. Now, an alternative test site is free, isn't it?
Absolutely free.
Is completely paid for. That's really great.
One thing I would like to add on the confidential is that you have to sign a consent, a written consent form. So that's a very big difference between anonymous.
So you're signing your name to a piece of paper, whereas the anonymous site, it's strictly a code number, and they don't have your phone number and your address. Now, you're from the State Office of AIDS. What exactly is it you do in Sacramento?
Well, I run the testing unit for California, which is encompasses all the anonymous testing, which is 101 sites in 37 counties, and the confidential program, which encompasses many programs, alcohol and drug, family planning, Indian health, and STD programs. We also fund early intervention programs, pilot care. We're working with home-based care for persons with AIDS. We have education and prevention projects, and we also develop epidemiological studies and research. So it's very comprehensive, and it's facilitating funding at the local level to combat the disease.
Okay, now Dean, you're at AIDS Project Los Angeles, and you are in charge really of a lot of this new education, these new posters and PSAs and things that are coming out. What is it you're doing?
Right now, well, this program has a history with APLA, about 5 years. We've been working with the state in various capacities to get the message out about testing to at-risk populations. I think we've come a long way since the beginning. We have recently done a series of television, radio public service announcements in addition to a very well-received billboard campaign, which I brought a,
okay.
a copy
This is
of
the billboard.
here. Anyone in LA should have seen this earlier this year. In addition, we also ran this in Riverside County. We ran it in Alameda County and San Diego. All over the state, we are also looking to do a second phase of this campaign in 5 additional new counties statewide this year. That's one of the many elements that we do to try to market testing to the people most at need.
Now that's pretty much to the point. I mean, that flat out says, get tested.
Right.
So at this point, really, you're advocating that people should be tested.
We are. AIDS Project LA, as well as a lot of people in the community, have come full circle with the testing issue. 10 years ago, there was a lot of reason not to test. What would you do with that knowledge? There was a lot of fear of discrimination. Discrimination still exists, but more importantly for the individual, what would you do with the knowledge if you had no resources? We have early intervention now. We know that it is effective. Early detection and early treatment of HIV absolutely prolongs the quality and quantity of the life of the individual. So at this point, resources are available. They could be more available, but they're there. If people educate themselves and find out educate themselves about HIV and what the options are, they're going to find that there are options. So there's no reason not to test now.
Now, Jordana, I've heard that the test, some forms of the test are in fact more accurate at this point than they were in the early days?
Right, that's true. That right now, most of the time when someone is testing positive, that test is repeated many times and a Western blot is done. So a chance of a false positive is very, very rare.
So are a lot of people getting retested in light of this, of the new knowledge about being tested and the importance of it? Are they getting
I think
business?
A lot of people tend to test on a regular basis anyway. And so we do get a lot of repeat testers.
Now, a lot of the things in this education program, some of these posters that I've been seeing are quite different from some of the things that have been used to educate people about the need to be tested before. Do you have some of the black and whites there you can show us?
I've got, this is a print campaign which we're running right now to essentially targeting the gay male population. We're running this to Latinos and blacks as well. The state has come a long way. And APLA plays a very important advocacy role in making sure that the materials are not only relevant, but as explicit as possible. We are talking about sexual behaviors here for the most part, talking about very sensitive subjects. We have currently an administration at Office of AIDS that is now very receptive and very understanding of the community's needs. And APLA just pushes them a little bit each year to make sure that we're doing what needs to be done and we're using the language that needs to be used. It's a lot stronger than previous efforts.
That's something I've seen. I mean, there's these posters, there's one poster, there's people actually lying on a bed, and this was something that I didn't see before, and I mean, I'm pleased to see this. Mary, what is the change in Sacramento that we're getting all this wonderful stuff now? I mean, this is being funded by the state. I'm not seeing someone laying down the law, no, you can't put that in a poster.
Well, there have been changes, and I think this campaign does speak to that. I personally attribute it to the work on APLA to be very candid with us. We do extensive research and community focus group organizing, groups that really speak to the affected populations. And I think that that is translating. We recently had a change in administration. There's a big focus on prevention. And if we are going to have prevention campaigns, people need the information. And that comes via education and prevention projects and the pre-test session, because we want to keep people who are negative in the future. And so this campaign really speaks to that. And I think Dr. Kaiser, as well as Dr. Coy, Wayne Saceda, and other people at the state office can be attributed to allowing us to go forth with a more aggressive and straightforward campaign.
I'm really pleased to see that. So now the focus is such on prevention that it's we do whatever we have to do. That's really good to see. These campaigns, they're targeting a lot of different people who may not have been targeted. I mean, a lot of us are used to the idea of telling gay men to get tested, but I've noticed that some of the public service announcements are targeted to minorities, women, even specifically to drug users. How did this come about? How did you create these programs?
Well, we're obviously trying to target at-risk populations, and the demographics of the disease are simply that we're seeing not only the gay population, but unfortunately now we're seeing the black population, Latino population, women, injection drug users have always been at risk. They're very specific subtleties.
That's kind of everybody.
That's just about
I mean,
everyone.
you kind of named pretty much everyone
Or everyone
on Earth. I don't-
probably knows someone
Yeah,
in one of those groups. Anyway, it's a much broader based thing. We go through a lot of pains, if you will, to access these groups as well. The subtleties are important. We do a lot of our materials in Spanish. We're just getting into Asian language materials this year. We have community review panels set up statewide. These are health educators, health professionals, sometimes journalists, people in the community, women's, blacks, Latinos, Asians, gays, lesbians. And we ask them, what do you need? What's the information for your community that you've not heard yet? How do you need to see it? Every single piece of material we produce, whether it's outreach or a brochure or poster for use at the test site, is field tested. It's also focus tested with people that are actually in the consumer group we're trying to access. So we go through. Cultural diversity is very important. It's very important to speak to these people on their own terms.
Just sort of a road-tested campaign,
Absolutely,
as it were.
Well, I'd also
extensively.
like to add that we keep very sophisticated records on all clients who enter state-funded testing programs. All the counselors complete a data sheet that profiles the individual, their risk behavior, their background, the last time they tested. So we profile that on a county and a statewide basis. So we use that data, we give it to APLA, they in turn go to the communities that we've identified at highest risk. Although testing data is not seroprevalence per se, it's a good snapshot of where infection rates are throughout California. So that gives them some indication of what our statewide priorities are. And like I said, they go forth and then research and do the community work from there.
Now that's something I'd want to know too. When you say testing data, do you know from the anonymous test sites how many people are testing positive and negative?
Yes, we do.
You do, but you don't necessarily know who.
Right, we don't know who.
But are the records kept that it's women or that it's men, and people check off those kind of statistics?
Yes. Yeah, we break it down by gender, risk behavior, age, ethnicity.
So if I were to go to get tested, say at Edelman, it would go on record that a white female da-da-da-da-da-da-da was tested, that I was negative or positive, and that would be it.
Right.
Now, what happens, what is the experience of someone who walks in the door to be tested? Because I think that's people's fear is, will it hurt? What will you do to me? What is going to happen when I go? What happens to someone if they walk in the door and say, okay, I'm here, I want to be tested?
Okay. We have people, because it's anonymous, they don't give their name. We have a 2-letter, 2-number code system, and people will come in by appointment, and they'll watch a video, they'll be given education materials, and they'll have an individual session with a pre-test counselor. They'll come back a week later for their test results, which they must get in person, not over the telephone, because it's such a complex issue.
You don't get a postcard in the mail for this.
Right, exactly, exactly. And they'll meet with a post-test counselor. And at our center, all of the post-test counselors are mental health professionals, because clearly it does bring up such important issues, and people still have a lot of questions.
So there is someone there with you. Now, say you test positive. What happens? Do they just say, well, we're really sorry, and send you home? What happens to you if you're at the center and they tell you you're positive?
This is one of the advantages of coming to a place like us, where we are set up for more comprehensive care, that we are part of a larger health system, a health clinic, where we have early intervention programs in terms of an AIDS triage clinic. If someone tests positive, then they are referred for a T-cell count, and depending on their T-cell count, they may become part of our AIDS prevention clinic or our West Hollywood clinic,
So
where
there's
they're referred
a
for
lot
ongoing
that you can
care.
send them to. We're actually going to look at one of the PSAs, one of the TV spots. We're going to take a look at this now, and we'll come right back.
If you don't think this deck is stacked against you, think again. Take the AIDS antibody test. You might prolong your life and the life of someone you love.
I like the music. Now, who thinks this up? Who came up with the idea, let's have a card game? let's do this. Let's have these people come in and play cards and show these risk factors and all of this. Who creates this concept?
Well, what we do is we try to apply standard marketing and advertising principles to this. In fact, we are marketing something. We're marketing the test, and specifically the anonymous test that the state provides. We retain production companies that are professional commercial production companies to work with us and help us develop preliminary scripts, which we then test with through our focus groups, and then with our health educators, and it needs to really pass about 4 different checkpoints before you get to see what you just saw.
So you really are making commercials.
Yeah, we are.
This
Yes, we
is
are.
a campaign.
Absolutely.
Do you have the other poster in there, under there?
I have,
wanna show me what
no,
they
I haven't.
Oh, you have the other one.
No,
Oh,
this
there's-
is another
oh, that's a
print-
nice one. Show 'em that
This
one.
is another print
Can't
ad
test it. No, you're
in a series. This is a series of 12 different print ads, which are being featured in gay publications. But we also do the brochure and poster series, and you saw one earlier. Unfortunately, I don't have it with me here.
But that was one of the ones that was interesting because it showed a man and a woman and a baby, and then there was a
Right.
picture of a man lying on a bed with another man, and the implication that a woman may not know that the man she's sleeping with is sleeping with other people, including men.
That particular poster targeted injection drug users, but clearly we were going for another audience, and that is bisexual men and partners of bisexual men, partners of users, which kind of segues into the women's issues, which is the campaign we're about to undertake, is to get very aggressive and do a 3-pronged campaign targeting women in the state of California. Women have sometimes risk factors that they're not even aware of because of their partners, and that poses a lot of problems, and it's going to be very difficult to reach women that are completely oblivious to their risk because they're not aware of what their partner might be engaging in.
Now, the people who come in to be tested, is this working? Are more people getting tested?
We are definitely seeing a lot more first-time testers. Since the beginning of this program, our first-time testers have about doubled. What's especially interesting about this population is that the positivity rate, the people testing positive, tend to be much higher than our average, which is about 12%. The first-time testers is about 20% positivity rate.
So a lot of people who were walking around positive and didn't know it are finding out now.
Right, which is especially important now because, as Dean was mentioning, there are so many early intervention things that could be done at this point.
Are the people more knowledgeable? Is the average person who comes in to be tested, have they been reading these things? Or do they come in and do they seem to know what they're about, that what their risks are and what the test
We
means?
really seem to see a split of people that are just beginning to realize that they might be somebody at risk. As opposed to people that could probably teach their own workshops on safe sex. But what's similar with these two groups is that they are coming to test, or they are coming back to test because they're continuing high-risk behaviors.
Are more women testing positive?
More women are coming in to test, and so more women are testing positive. And it's certainly a very high-risk population at this point, that probably the highest rate of new infection is among heterosexual women. And I think a lot of people who aren't used to seeing themselves at risk really are.
Now, a lot of these people who don't see themselves at risk, a lot of the women, are they surprised? Are the women who test positive, do they say, well, I thought I might have been, or is it a complete shock?
Well, I think the fact that women came in, that the woman has come in, that there has been a suspicion there. They have been having reoccurring infections, or they've been having difficulties that haven't been going away. I think with women it's particularly difficult because there is no sense of community. It's very hard for them to find a support group they feel comfortable in, to tell their friends, to tell their family, to negotiate safe sex, that there's a lot more complicated issues for women that are just testing positive.
Something that I think a lot of people don't realize, what are some of the recurring infections that do hit women that might be an indicator that if a woman is watching now and has been having these problems, that she might want to check into this?
Well, one thing to keep in mind is that any symptom of HIV is also symptoms of a lot of other things.
Right.
But one thing that women might want to be aware of are recurring vaginal infections, PIDs, anything of that nature that doesn't seem to be going away. It's important to talk to their doctor about it.
I mean, anyone can get yeast, but they're seeing that a lot of people are having yeast again and again, in fact, that this is an indication of HIV infection. Now, from the state, are you seeing, across the board, are you seeing more women testing positive in the numbers you're getting?
Well, we've always serviced a large population of women. About 42% of the women who come in test through the anonymous testing program. Overall, our positivity rate is about 1% of that group is positive. And most of them identify no risk other than being a heterosexual partner of someone. So it's very interesting. We don't have current data that will reflect the campaign. So I'm working on data that was still reflective of 1990. So we should see some changes. You know,
now, one of the things that comes up, of course, all the time is the topic of mandatory testing, testing of doctors, dentists, testing of patients for the doctors and dentists, testing of everyone, testing of healthcare workers, and around and around. How do you feel about this? Is this really something that needs to be done? Is this something that is only going to complicate things further? Is this a mistake?
Well, I think the risk of infection from a healthcare worker to an individual client, patient, is very low because of universal precautions that most people employ. I think we have rare occurrences like the incident in Florida that certainly has a highly charged emotional response and gets the attention of certain legislators. But overall, I think if people are employing good precautionary measures, the incident or the risk is very low. In terms of mandatory testing, I think first we have to look at costs. You know, it is very, very costly to run a testing program. The ATS program alone runs over $5 million, and that's just one aspect of a larger testing program that's state funded. To have mandatory testing would be, as I said, very costly. I think secondly, we have to look at the discriminatory aspect of HIV infection. We still don't have certain precaution or certain laws in place that protect people, you know, particularly for gay and lesbians. There is a big risk for being found out for men who are positive and having that assumption made, housing, their jobs, etc., all aspects of their lives. And even if anti-discrimination laws are passed, as with civil rights laws, you know, we certainly aren't going to have assurances that it's going to stop. So from a public policy perspective and a state perspective, those are two very important issues, not to mention the low incident or possible incident of transmission.
So then the anonymous testing at least provides a place where people can get tested without having to
Certainly, and
deal
healthcare
with the
providers do
discriminatory
access
aspects.
ATS, the anonymous testing program.
So someone could go there too if they were concerned about their dentist for whatever reason.
Right, yeah. I also share Mary's concern in terms of the punitive aspects, in terms of mandatory testing, as opposed to preventative aspects. And I think when we see more sort of systems in place for people who do test positive and what to do on an anti-discriminatory basis, then that might be a more appropriate setting at that time. But right now, the way it's in place, it's more from a punitive aspect rather than what will happen when people test positive. The idea of retraining at this point seems to be similar to these people will be unemployed.
One of the things that people often ask is, how long does it take to test positive? I mean, there is a window period. There are people who can test negative and still have the virus. And a lot of people aren't real clear on these numbers because they know it takes a long time to develop AIDS. Can you clear this up for us and explain exactly what you get with a test?
Sure, yeah. When people are infected, it could take as quickly as 2 weeks to develop antibodies, which is what the tests look for, antibodies to the virus. It can also take as long as 6 months to develop antibodies. So we use the 6-month time period to make the test as accurate as possible. So if somebody felt they were at risk in a situation 2 months ago, it's possible they could be testing negative and still have yet to develop the antibodies.
Now, how do you get some of these things across? Do you feel that in the testing campaign you're making it clear that it's a test for the antibodies as opposed to AIDS, the actual disease? And how do you walk that line?
That's actually a good question. We've actually gotten some criticism. My sense is that in terms of mass media marketing, which is a lot of times what we employ, you can't get real specific. We've used the words, in the spot you just saw, we used AIDS test. We get a lot of flack for that, but people know what that is. We are now shifting, and you can see it in this poster, we are using HIV testing. We're starting to push HIV because that is in fact what we're testing for, antibodies to HIV, not the AIDS virus. But it's a process. You've got to bring people to that understanding. You just can't start throwing around HIV and expect that everyone's going to know what you're talking about.
Well, it's like on the show, when we have to say alternative test site if we just said ATS for the whole half hour.
Exactly.
I think that it was interesting that in the spot, even though they showed the card that said AIDS test, the voiceover said the HIV antibody test, sort of connecting the two. is this an attempt to start to educate people who've been calling it the AIDS test to HIV?
Absolutely. The way to accomplish that is to link the two first, and then hopefully at some point we can drop using words like AIDS virus and AIDS test. We can drop using that altogether because it's not really correct. But it's a process. You've got to educate people through a process.
Is this working? Do people, when they find out they test positive, do they think that this means they have full-blown AIDS or that they're going to go into it immediately? Is this?
Well, at every process through our testing, through the pre- and post-test counseling, we continually reinforce the difference between HIV positive and AIDS. So the first thing we tell people when they test positive is this does not mean you have AIDS, and that we're continually doing that education on a lot of different levels.
Are you getting any resistance to the campaign? I mean, you mentioned the criticism about the confusion of HIV, but are you getting any flack from people saying, well, you shouldn't be doing that, you're being too explicit, you're talking about sex, you're talking about drugs?
Surprisingly enough, this time around, we met with a little bit of resistance when we said "get tested" on huge billboards. People thought that was, boy, is that strong. But when we tested this with the consumer, the actual person on the street with maybe not very AIDS literate, they said, if you want to motivate people to get them into the test site, you've got to have to hit us over the head with this message. Don't dance around it. Say what you mean. So we got real explicit, and we just said, hey, get tested.
Buy Coke, get tested. This is just
do it. Just do it.
I would just like to add one thing. We've received very positive response. For the state to have such a straightforward message. We've been getting a lot of accolades for that, and I really thank KPLA for, promoting the clarity of the message. But I think also in terms of flack, I think the biggest problem has been the increase in testing and being able to fund it all, because the response has been overwhelming.
Thank you for coming on the show and for showing us these posters. You'll be seeing these spots on TV. You'll be seeing these posters. You can get in touch with AIDS Project Los Angeles for more information, and you can get in touch with the Edelman Center. Is that where would you like to give the number for that, or just should they call the hotline number?
The number to be tested is 464-7276.
And you can call, make an appointment. Thank you all for coming. And if you want to just say, get tested, watch AIDS Vision, and thank you.
Thanks.
Good, thanks.